so much, and welcome to tonight's webinar. My name is Ann Lee, and I'm the Programs Associate for Can Do MS. Thank you for joining us for this evening's webinar about bladder and bowel issues presented by Susan Kalota, Certified Urologist, and Pat Kennedy, Registered Nurse. If you are not already familiar with what Can Do MS does, we provide programs for people living with multiple sclerosis and their support partners. Our programs empower people to move beyond their MS by giving them the knowledge, skills, tools, and confidence to adopt healthy lifestyle behaviors, actively co-manage their disease, and live their best lives. And you can learn more about these programs by going to our website at www.mscando.org. You can register for upcoming webinars. You can also listen to and play back our recorded archived webinars. And you can also learn about our live programs, our Can Do program, our Jumpstart programs, and our new Take Charge programs. You can also ask your questions through our website with the Ask the Can Do team, and your questions will go directly to our experts. And just a few housekeeping items before we get started. As mentioned previously, you can ask your questions through our chat feature below. We will have a Q&A session at the end of the program, and we will try to answer as many questions as time allows. So on your screen here, you'll see the chat feature on the bottom left-hand corner, and just type in your questions with the box that says Chat with the Presenter, and we will try to get to your questions during the last portion of the webinar. This presentation is being recorded and will be archived on Can Do MS's website. All of our monthly webinars are archived on our website, and you can view them again at any time. You can also view the webinar schedule and register for upcoming webinars. For those of you who are attending tonight's live session, you will receive an email with a copy of tonight's PowerPoint presentation in a PDF format. And also, please complete the evaluation at the end of the webinar. We value everyone's feedback. I'd like to now introduce our presenters for this evening's webinar. Dr. Susan Kalota is certified with the American Board of Urology and holds the distinction of being the first female urologist in Arizona. Dr. Kalota graduated as salutatorian and received her medical degree from Howard University College of Medicine in Washington, D.C. She completed her internship and residency at the University of California, San Diego, with a brief stint at the Institute of Urology in London, England. Dr. Kalota participated in the Peace Corps in the Ivory Coast of West Africa and developed a Well Baby program. She is director of the Urodynamics and Continence Lab at Tucson Medical Center. She holds memberships in many local and national organizations, including the American Urologic Association. She is past president of Society of Women in Urology and founding president of Tucson Society of Women Physicians. She is on the board and participates in volunteer medical trips internationally with IVU Med, as well as volunteering nationally with Can Do MS. Pat Kennedy has been working in the field of multiple sclerosis since 1987. Initially, she worked as a nurse practitioner in a large comprehensive MS center and now works for Can Do Multiple Sclerosis as a nurse educator for staff and community and as a program advisor for organization. Pat sits on the Client Education Committee for the National MS Society. She is president of the Board of International Organization of MS Nurses and is certified as a multiple sclerosis nurse. And she serves on the editorial board for the International Journal of MS Care. Pat has had the opportunity to speak to people living with MS as well as professional audiences internationally. She contributes to many publications and books and is the editor of a new book written by a multidisciplinary team of professionals who work as staff for Can Do MS. The book is titled The Can Do Multiple Sclerosis Guide to Lifestyle Empowerment, published by Demos Medical Publishing. We can talk more about the book later at the end of this webinar. And now I'd like to turn the controls over to Dr. Kalota.
Hello. I'm a urologist in Tucson, Arizona, and not all that good on computers, so we're going to have help here. But my job tonight is talking about the bladder, which I am good at. So we're talking about the bladder and how it affects someone with MS. First off, we're going to talk about the bladder function. That's the first slide. And the normal function is to store urine and then to empty when socially acceptable. Next slide. To do that, it needs to be very elastic, very stretchy, which is called highly compliant. It needs to maintain low pressures. so that the bladder can fill easily, and it should be continent, which means that it doesn't leak. Next slide. So what's involved with that? It actually is a very, very complex interaction between the bladder muscle. You need a normal bladder. You need a competent urethra so it doesn't leak out the urethra. You need normal nerves in the pelvis, normal spinal nerves, and a brain that functions normal, and not just in one site, but in multiple different spots within the brain. And unfortunately, all those last three can be affected by the MS. Next slide. So the reason we're talking about bladder problems is that bladder dysfunction, so not normal function, occurs in 50 to 80% of people with MS. At some point in time, they're going to have problems with their urination. Next slide. What does that mean to you? That might mean you've got an urgency, you've got to rush to the bathroom to urinate. You may leak urine. You may find that you have to go all the time, or at least more frequently than you did before, or more frequently than your friends. Or you may have difficulty or even complete inability to get started on urination, to void it all, or to completely empty. Next slide. And what does that mean medically? That means a whole bunch of big fancy words that we'll go into: detrusor hyperreflexia, urethral sphincter dysfunction, or impaired detrusor contractility. Detrusor hyperreflexia means the detrusor, which is the bladder muscle, is overactive. It's spastic. And that is the most common abnormality in the bladder in people with MS, and occurs in 50 to 90% of the patients. And it can be isolated by itself, or it could be with any of the other issues as well. Next slide. Excuse me. So, urethral sphincter dysfunction. Here's more big words. So, detrusor is the word for the bladder. Sphincter is the urethra, which should be a closed door when you want to be dry and an open door when you want to urinate. And synergistic means that they work together appropriately. So dysynergic means they don't work together appropriately. So when the bladder contracts, meaning you want to urinate, the urethra should relax and let the urine out. If it's not working together, that means when the bladder contracts, the urethra tightens, and instead of opening up to allow it to flow easily, it tightens and makes the bladder work much, much harder, and you get higher pressures. So that's not working together, or dysynergia. You could have a less problematic situation where the urethra just doesn't, uninhibited. It's when the urethra relaxes when you don't want it to. So when it should be tightening and should be keeping you dry, it suddenly relaxes and you leak. Or the last one, urethral non-relaxation, is when the urethra doesn't tighten, but it also doesn't loosen or relax when you urinate. So it's not quite as bad as the first one, but still not normal. And next slide. Oh, impaired detrusor contractility, which I guess I didn't give you a slide on, means that the bladder muscle does not work like it should. So instead of contracting or trying to push the urine out, it just doesn't push it out. So you're not emptying the way you should. Sometimes you can still empty with straining, but it doesn't work normally. So the test that I might order as a urologist to look at this is something called urodynamic studies, also called a CMG, also called a bladder function test. And that's the Cadillac to look at the whole picture. But we might just do a bladder scan to check and see if you're emptying. And that means that we're doing an ultrasound, just running a machine over your lower bladder, lower abdomen, to check what's left behind in your bladder. Or we may want to look at your kidneys with an ultrasound, a CAT scan, or a VCUG is voiding cystourethrogram. So that's a study that we're checking when you're urinating to make sure the urine's going just in the right direction, which is out, instead of back up to your kidney. And why might we do all these studies? Why are we looking at your bladder? And next slide. Because there's health risks along with the quality of life issues. So from your standpoint, you may be saying, I don't want to leak, I don't want to be going all the time. But the health risk is if you don't have a normally functioning bladder, it could affect your kidneys. It could give you kidney infections. It also could ultimately lead to kidney damage, and we don't want that to happen. Next slide. The people who have the highest risk for injury to their kidneys and problems are twofold. Women with an indwelling catheter. So you'd think that, okay, if you're having bladder problems, let's just put a catheter in and that'll take care of things. But it doesn't. And women in particular have problems with the catheter because of bladder issues, but also if they're sick enough to be having a catheter in, potentially they're sitting on their urethra all day long, and that urethra can slowly require bigger and bigger catheters, and it's almost like a pressure sore in the urethra. So you start with a little catheter and start leaking around it, and then get a bigger catheter and leak around it and bigger. So that can really cause problems. And then men with the detrusor sphincter dyssynergia, that means that the bladder and the urethra are not working together, and pressures in the bladder can start getting higher and higher and cause problems in the kidney. And the reason men have a bigger problem with that is that with their prostate, they have a worse chance of developing high pressures without knowing it, where women are more likely to leak. But just in general, any male or female with a catheter in the urethra is at higher risk of problems. Anybody with the detrusor sphincter dyssynergia is at risk for higher problems. Just one second, my computer went funny for a second here. And then anybody with problems in their bladder where the bladder pressures are above 40 centimeters of water. And that's nothing that you generally are going to have a problem with if you're followed by a urologist and can keep an eye on that. It has to be high for a long time. So we just want to keep an eye on those people. So next slide. The goals are both the prevention of the complication and the reduction of the symptoms. So I want to protect your kidneys, and you want to avoid the leakage and the problems urinating, and infection and finding bathrooms all over. Next slide. We have several options for this. We can do behavioral changes, medications, intermittent catheterization, or surgery. And we'll talk about that. Next slide. Behavioral modification can be as simple as restricting fluids if you're drinking lots and lots of fluids, or avoiding dietary irritants. So the big gulp of a huge cup of coffee or soda or stuff like that can cause bladder irritability. And if you're drinking lots of fluids, you can avoid that when you're out and about. However, you don't want to avoid fluids constantly because you'll be at more risk for infection or you'll be at risk for stones. So the fluid restriction would be just if you're going to go out this afternoon and you don't want to be going all the time, you might avoid some fluids, but not always. If you have trouble urinating and emptying your bladder, you may find that you can urinate once, wait a few minutes, urinate again, and maybe even urinate a third time, or urinate once, stand up, sit back down, and urinate again. And if you take the extra time, you might be able to empty your bladder. Timed voiding means that if you tend to leak every 3 hours, you try and go every 2 hours. So you're trying to go before you get into trouble. Biofeedback is just learning to control the pelvic muscles, and sometimes we can train the bladder so that it's not as problematic. Next slide. Now, medications are several categories: bladder relaxants, muscle relaxants, and medications to tighten the bladder neck or the urethra. That last one is more for ladies who leak when they cough or sneeze or laugh. And sometimes even the medications that we're using are the medications for like colds and allergies. If on the package it says be careful in men with enlarged prostate or people who have problems urinating, then it potentially could help you avoid leakage with coughing and sneezing if it's not much of a problem. The other two categories will go on to the next slide. Bladder relaxants. These are the ones most commonly used for people with an overactive bladder, and that's the urgency and the rush to the bathroom and maybe not make it. And for the general category of neurogenic bladder. So you can see there's a huge list of medications, and any of them could be helpful. Your doctor can pick and choose, and whichever works best for you is really the best one to be using. Next slide. The muscle relaxants, most of the time the urologists are not going to be using the skeletal muscle relaxants. Those may be more used by your neurologist, but sometimes they can relax the urethra. So in detrusor sphincter dyssynergia, where we've got that tight urethra, the skeletal muscle relaxants can be helpful. Likewise, the bladder neck muscle relaxants, which are used primarily in men with prostate problems, they also can help sometimes relax that urethra and the area just at the opening of the bladder. So in people who have difficulty emptying, sometimes they can be helpful. Next slide. Now this one, most people get really upset when they need to think about catheterization. And you'll remember earlier on a slide I said a catheter is not great, and that was talking about a catheter in all the time. But the clean intermittent catheterization means that you're going to put a catheter in the bladder and drain your bladder. And you're going to do that periodically throughout the day. So in someone who cannot urinate, that's a way of emptying the bladder. And in those who have the detrusor sphincter dyssynergia and have high pressure urination where it's really not safe, then putting a catheter in bypassing that sphincter is very helpful. Where you might find it beneficial is if you've got a problem where you can't get your urine out or it takes you forever. I had one girlfriend who was also a patient who every time she needed to urinate, it would take her 20 minutes to try and get the urine out, and she may give up after that time and still have not gone. When we started her on intermittent catheterization, she knew she could go into the bathroom. It was going to take her a couple minutes. She could guarantee that she was going to get in there, get her bladder drained, and get out. It didn't take as long, and she knew it would get done. So sometimes it can actually be very liberating. Where it also works is sometimes when we use medications to relax the bladder, where we can get it too relaxed, and then you aren't emptying, and we need to add the intermittent catheterization. So between the medication and the catheterization, we can get you dry and we can get you empty. Next slide. Well, if we have not succeeded with medication or the catheter, or you can't do the catheterization, we can go on to surgery. And it used to be that bladder augmentation was pretty much our best option other than urinary diversion, which we'll get into. But now I'm actually going to have you look at the bottom of the slide, the Botox bladder injections. And no, it's not for wrinkles in your bladder. You've probably heard of Botox for cosmetic stuff. But it gets rid of your facial wrinkles by relaxing those muscles. In the bladder, we're injecting it into the muscle of the bladder. And that also is working to relax those muscles so they're not spastic, so they're not contracting all the time. And the pressures go down, you can hold more, and that can be very helpful. Bladder augmentation means that we're actually enlarging the bladder, and that's a pretty big surgery. Urinary diversion may mean that we're going to do a surgery to bring the urine to the skin, so you actually use an ostomy bag. That's pretty drastic, but in some people that's a godsend. A suprapubic catheter, the third one down there, is a catheter like we spoke of before, but instead of coming out of the urethra or penis in guys, it's coming out of your lower abdomen. And it has fewer problems than the one coming out the normal way because you're not sitting on it. Sphincterotomy is only for guys, and that's where we cut the sphincter, so then it can't be in spasm. And that's occasionally still used. Prostatic stents are metal stents in the prostate area. Used to be fairly popular, but not anymore. And then the next to the last, neural stimulation can be done almost like a pacemaker to the bladder, so you have an implantable little computer part and then a wire to the nerves in the sacrum, or peripheral nerve stimulation, PTNS, and that's an office procedure once a week where we just stimulate a nerve down by your ankle that then goes up and helps stimulate the nerve to the bladder. So all kinds of new stuff going on, lots of different options to both get you dry, allow you to empty your bladder, and keep your kidneys safe. Next slide. The main thing that I wanted to show on this slide, waxing and waning, is that in MS things can get better, can get worse, and so you don't want to jump to major intervention when minor stuff might work. But on the other hand, we do want to prevent major medical problems. So that's my presentation. Any questions?
Well, we can take questions at the end of the webinar, and we'll let Pat take over the controls for her portion of the webinar.
Well, good evening, everybody, and here we are, oddly enough, on a telephone call with people I don't know, and you don't know me, but we're going to talk about those kinds of things that you probably don't get a chance to talk about in many situations. And so what I'd like to do tonight is open the door for you to understand a little bit about what's going on with your bowels, and why they might not be working properly, and how you might talk to your healthcare provider to see what other options are available to you to allow you to work on the bowels. I will tell you that much of what you can do for your bowels to make them work better for you is something that you can do yourself. And so we're going to go through those, and we'll talk about the things that you'll be able to do yourself. So I clicked on the next slide. Can you move me in? Thank you. So in MS, pretty much what we see are two things. One is we see a lot of people who complain of constipation. And then we have a number of those people who also or may only complain of loss of control of their bowels, both of which are major, major problems in lifestyle and moving on and getting out and being out in society. And so that's why we want to talk about it. That's why we think that this is important, and we should move on with it. All right. So what causes bowel problems in MS? Well, first of all, you have MS. And that in and of itself, because of neurologic problems that cause slowing of the stimulation to the nerves that affect the bowels, that will cause a change in the way that the bowels behave. So that's the very first and utmost of the issues that you might experience. You might have weakness in your abdominal muscles. When you go to push to remove a bowel movement, it may be harder for you because your abdominal muscles are not as strong as they once were. Just like many of your muscles may be a little bit weaker, so may those. You may have also spasticity, that thing that causes your legs to be stiff or your arms to be stiff. You can have spasticity in your pelvic muscles. And those pelvic muscles are the muscles that sort of wrap themselves around the lower end of your colon and your rectum, and they help to keep the stool in until it's appropriate to let it out. But if you have spasticity, what that means is that the stool that's in the rectum at that point in time can't get out because the muscles are squeezing too hard to keep it in. Not unlike what you heard about in the bladder. You can have sensory loss, which means that the waste in your body moves through your gut and it gets down to the rectum. Normally you would get some sort of a message that, oh my goodness, I need to go to the bathroom. But when you have decreased sensation in the rectal area, you may not get that message. And when you don't get that message, then the bowel may fill up and you're not aware that it's filling, or the reverse is that it's filling and then all of a sudden it decides to let go and you're not aware that it's going to do that. You also might be having a poorer diet than you normally would because it's just not as easy to prepare food that is good for you. You might be reducing your fluids because you have bladder issues, and that's what many people with MS do. And if you reduce your fluids, you're going to have more problems with your bowels. So that kind of goes hand in hand. You might have decreased activity. So for those of you who are not as up and about as you used to be, you may be sitting more, you're going to have more difficulty with your bowels because that movement and that gravity of being up on your feet is what helps our bowels to move. Some of the medications that we give you for MS and other symptoms may in fact cause an increase in constipation. It may also cause an increase in bowel motility. You might have looser, more frequent stools. You might have decreased attention to the signals that you have to go, and that's either because you get busy, maybe cognitively, you're not thinking as much about bowels when your mind is on other things. And so you're not going when the message is there. And you may have trouble just simply getting to the bathroom and getting your clothes off and getting your clothes, down so you can get to the toilet appropriately. So some basics about bowel movements. Food and fluids that you take in through the mouth are processed through the stomach and go into the small bowel. During that course of moving the waste through the small bowel and then the large bowel, fluids are reabsorbed by the body for other use. Waste in most people, with or without MS, it moves at a consistent rate. So some people may experience that waste goes through quickly. They may have a bowel movement 2 or 3 times a day. Other people, it may move more slowly, and they may have a bowel movement every 2 or 3 days, and that's normal for them. But when that waste slows down because of all those neurologic things I talked about, more fluids then get absorbed, because that's what they're supposed to do in the bowel, in the gut, and the stool then gets drier. Dry stool that ends up at the end is less able to move through the bowel. Dry stool, when it enters the lower colon and the rectum, stays there. And it just blocks everything up, and it blocks all the waste behind it. So over time, the waste volume in the rectum is large and hard to pass. Decreased sensation that you might have ordinarily had in the rectum may prevent the brain from recognizing that the rectum is filling, and may not give you the message that you really ought to attend to this. Then stool blockage itself, when that hard stool is there, as new waste comes down through the gut, it's more liquid. And when it gets caught up behind that old stool, then what happens is it comes around that stool and it comes out as diarrhea. So what can you do to improve your function? Well, first of all, there are dietary measures, and I said there are some things you guys can do, and that's to enrich your diet with higher fiber foods. And for this you need to read your labels, but you need about 30 grams of fiber a day. That's a lot of fiber. That's hard for many people to get in. We want you to increase fluids as able, but if you have bladder issues, it's probably wise to get those bladder issues managed first, and then you can deal better with the bowel issues. But we also want you to move more, however you can do that best. And, for many of you, I'm not talking about an exercise program. I'm just talking about maybe just a few steps around, just things to move your body about. Wear clothing that is easier to remove when you get to the bathroom. And then you might want to, if your bathroom is awkward and you've got the urge to have a bowel movement and you can't get your body in your wheelchair or your walker in there, you may want to talk to an occupational or a physical therapist and figure out how you might do that better. So you can regulate your system just like when you were 2 years old. I'll bet you that all of your mamas did this, and you can do it again, but it's just a little different now. So you can set up a bowel program, and what that means is you can choose a time of the day that is good for you to empty your bowels. And you think, well, I can't do that. Well, you can do that. It just takes perseverance. And so let's pick 9 o'clock in the morning. There is no magic to this, but morning tends to be best. You can make sure that you can stick to that time of day. So if you pick 9 a.m., but on Sunday you happen to be in church, well, that's not a good thing because your bowels may be trained, and that's not a good place to be. So pick a time that on every day of the week that you're going to be able to work on this program. And some people may have a daily bowel program. Others may have an every other day or an every third day. All of those are okay. I've heard couples argue about this all the time. Well, you only go once every 3 days. That's just not right. Well, it's okay. And for some people, that's just the way it is. But I don't want you going much more than 3 days without a bowel movement, because then you run that risk of things building up, stool getting bigger, not able to pass it. So you want to toilet at that time that you choose. You may, however, in the beginning need to have some stimulation to get that process started. And you can do that with something like a glycerin suppository. These are available over the counter. You may have to ask in some pharmacies because in hot weather they melt on the shelf, and so they may be kept in the back in the refrigerator. But glycerin suppositories only stimulate the very tail end of the whole system, but they may tell your victim, hey, she's trying to have a bowel movement, and that may get things started. So you need to establish that pattern, and it does take time. You just have to learn a little bit of patience. If your stool is really hard and dietary measures, you can't get that 30 grams of fiber in, consider maybe using something like bulk agents. And these include things like psyllium, Citracel, Benefiber, Fibercon, and there are others out there. And all of these, if taken, require that you do drink at least 6 glasses of water, because what these things do is they don't get absorbed, but they hold on to water, and they pass stool through the system in a wetter form, so it's more easy to pass. But if you don't drink enough water, then they go through as cement. So you want to make sure that you're drinking enough fluid, and it doesn't have to be water. It can be other forms of fluid. But just make sure you're getting fluid in, otherwise we may increase the problem. But if you take that on a daily basis, not as a laxative, but just to establish a program, bulk agents allow, again, that liquid to remain in the stool, so when it comes out on the other end, it's going to be softer and more bulky, giving more messages to the brain that the rectum is filling, and you should be able to empty a little bit better. If the stool softeners are also helpful for many, and also make the stool easier to pass by making it a little slipperier, as it were. Another product that is out there is called Enemies, and that's a rectal stimulant. It has a little bit of a stool softener in it, and it's put into the rectum and stimulates the rectum to contract and to be able to push that stool out. The glycerin suppositories that I mentioned before will help to stimulate the rectum. Digital stimulation, many folks use. This is not a medication, doesn't cost you a dime, but it requires that with the use of a finger, you can put a finger into the rectum with a glove on, and that will stimulate the rectum to want to contract and push out that stool. Miralax, which is a laxative by its label, is gentler than most laxatives, and it helps to also soften the stool. It's usually best if you have a bowel program starting or going, because it can work a little bit like a laxative, and it could catch you unawares. So you want to make sure that you're working on a bowel program. Laxatives and enemas are not suggested for regular use, and that's just, as the label will tell you, not meant to be used on a regular basis, because it will cause people to become reliant upon them, and you really can get some control on this on your own. If basic attempts aren't successful over a reasonable amount of time, and that's anywhere from 6 weeks to 2 months, or if pain occurs, or if blood is seen, you need to be then seen by a gastroenterologist, because you may have something besides a problem with your stool and your bowels and your MS. And so you need to look into this further. So bowel function is something you can manage better. I mean, I've had many patients over the many years I've been doing this, and they have had good success with this. Not everyone is successful, but many, many are. But always discuss these problems with your healthcare provider. And I know it's awkward. I know that sometimes they kind of look at you like, what? This isn't something I know something about. But it's a good thing to talk to them about it. And always inform your provider about what you're doing to improve your bowel function. Make sure that anything you're using or doing may not interact with something else that you're doing regarding your MS. So I'm hoping that some of these ideas are helpful for you, and I guess at this time, Anne, we can open this up for what questions you have received.
Absolutely, and thank you so much, Susan and Pat, for all of that information for this presentation. We did get quite a few questions throughout the webinar that was chatted to us. We've gotten several questions regarding a pacemaker. So the question is that they'd like to learn more about the pacemaker that is installed on the hip, and I think this question is for Susan.
Yeah, that's the interstim, or the sacral neuromodulator, and that so it's called interstim. Um, it can be very, very useful and helpful and effective. The main problem with MS is that you cannot do a MRI with it. So if you're someone who is being followed fairly closely with MRIs, that would not be good for you. But if you can get your neurologist to say that that's probably not going to be necessary, then that can be implanted. And the battery pack and kind of computer goes in the buttock fat and then the wire into the sacral area. And I often talk about it as being a pacemaker for the bladder because it's the same company, the same kind of battery, but the wire goes to the sacrum, to the nerves in that area rather than to the heart like a heart pacemaker.
Great. And we have a question for Pat on bowel issues. This person says, I've had major bowel issues now for 4 years. Everything I eat goes right through me. I've lost 30 pounds and I'm trying to hold my weight between 94 and 98 pounds, yet it is hard. Do you have any advice?
I read that question actually earlier, and I would tell you that this sounds less like an MS issue and more like some other issue having to do with your bowels. And I'm assuming you've seen a gastroenterologist, but there are ways to slow down a rapid moving, the motility of bowel function. And but I would sure want to make very sure that everything else is okay in the gastrointestinal system. So I can't say that this is a direct MS problem. It may be confounded by MS because it's harder to control those loose stools, but I'm not sure the genesis of the problem is MS.
Great. And we have another question for Susan regarding Botox. I had Botox injected in my bladder to address frequency problems. After the Botox, I've had much difficulty emptying my bladder. Do you have any suggestions of what might help?
The only thing that's going to help with that is if you're having significant problems, is intermittent catheterization. The Botox pretty much paralyzes for a period of time the bladder muscle, and it's not injected in the entire muscle. But some people, even though it's just paralyzing part of the muscle, they leave way too much urine behind and have too much trouble urinating. And in MS, sometimes the muscles don't work normally anyway, or maybe the urethra is too strong, like we said, the detrusor sphincter dyssynergia. So it's, in general, for someone who doesn't have MS, I say the chance of having to catheterize after Botox is about 5%. With MS, it's probably higher than that, and all you can do is catheterize intermittently until the Botox wears off.
Great. And we have another bowel question. Does or can sex affect the ability to or not to have proper bowel movements? And this came from a female.
Can sex affect that?
Yes, sexual activity.
Well, no, I think probably not. But of course, the neurologic system is such that the nervous interventions to the bladder and to the bowel and to the sexual organs are very much connected. I don't think it has a great deal to do with that, but during sex there can be some relaxation that occurs in both bladder as well as the lower bowel and the rectum. And so I suspect it is possible that a person could experience some loss of bowel during sex. My suggestion for that, if that is occurring, is if you're on a bowel program and let's pick that 9 a.m. hour, I don't care what hour it is, but if you're picking a time of day to empty your bowel, the likelihood of your needing to empty that again is less than if you were just waiting until you got the urge and you had to go. So my suggestion is a bowel program is probably the best solution for that. And if that doesn't work, then I think discussing it with your provider is a good idea.
Great. And just a few more. This question says, I've heard that the urodynamic test is humiliating. What exactly is involved with this test?
First of all, the people doing the test do it all the time. And as with many issues, it's a test on the bladder function. So you come in and you try and urinate normally into this machine, and the machine measures the speed of the urination and the pattern of the urination. And then a catheter is placed into the bladder and into the rectum, and then some patches next to the rectum. And the catheters are pressure monitors. So with the one in the bladder also allowing us to fill up the bladder with fluid. So as the bladder is filling, we're checking to see with the pressures whether there's spasms. The urodynamic tech may be looking in the vaginal area as they're filling to look for any leakage. So people think it may be embarrassing, but people think a pap smear and a pelvic exam by your gynecologist are embarrassing. The doctor or technician doing it is someone who does it day in and day out, and it's just normal stuff. But hopefully you have it done by someone who's compassionate and understanding. But it's just a really important test to see what's going on with the bladder.
And I think we have just time for one or two more questions. So we have, what are your thoughts on taking probiotic supplements? Any special considerations to be aware of regarding MS?
I think that's probably a question that I should answer in regards to the bowel. You know, the probiotics, there's a lot of mixed messages out there. They're probably helpful for you. I don't think there's any advice to not taking it. I think it's probably not a bad thing for people to take. It helps to restore just normal flora of the colon, and that's probably a good thing. Will it fix a problem that a person has where they're getting really constipated or they're having trouble controlling their bowel? I don't think it's going to that, but it may certainly help if a person has a tendency toward loose stools or other issues like that. So I don't have any cons for it, and it may be helpful for some people.
And it may be helpful for bladders too. So I don't see any downside to it, and nothing related to MS specifically.
Okay, and one final question. Are medications like Detrol meant to be used only as needed or constantly? And if the latter, constantly, are these side effects to long-term constant usage?
Okay, most of the time they are made to be used constantly. There are a few people who have just a bit of urgency and not too problematic leakage, and they just want to be able to go to a movie or go out to dinner or drive in a car, go to church or something like that. And then they might do well with a short-acting medication like generic oxybutynin. But the Detrol and the longer-acting ones work much better when you use them every day. They tend to take a couple of days to get the appropriate levels in the system. So I do have patients who take them just as needed, but I think you're better off taking them every day or taking a short-acting one just once in a while. And as far as long-term problems, all of these medications, if they have any side effects, they're I won't say they're immediately, but there's nothing that you need to look down the road that if you take them a longer amount of time, you're likely to develop a problem that won't go away. They tend to be associated with constipation and dry mouth, and any of the problems you have with it, you notice it. There's no problem going to be happening without your awareness. So all in all, you get what you see and don't have to worry about it.
Great. So that concludes our Q&A portion of this webinar, and I just wanted to thank you, Susan and Pat, so much for taking your time out of your evening to present for us, and also a big thank you to all of our participants who joined us for this webinar. Before I share the topic for our next month's webinar, I did want to revisit the book that I had mentioned at the beginning of our webinar that's been released by Can Do MS, and it's titled The Guide to Lifestyle Empowerment. The book was co-authored by several of our program staff, and it was edited by our very own Pat Kennedy, who is our presenter for this evening. You can visit our website at mscando.org and go to our Programs tab to find out more information about our book. Or to just read reviews or to order. Our next month's webinar is going to be on August 13th, 2013. It's at the same time, 8 p.m. Eastern. And the topic is Speech and Language Issues, How to Make Your Voice Heard. The presenter that evening will be our program consultants Janet DeClark and Pamela H. Miller. So please join us live from the convenience of your own home or office at no charge to you. You can register for our webinars at www.mscando.org/webinar. And for those participating live tonight, once this presentation is over and you click out of the webinar, you'll see a survey pop up on your computer screen. We very much appreciate if you can take a moment to complete the survey and share your input. Your feedback always helps us continue to improve our webinars. And you will also receive a copy of tonight's webinar slides by email. Thank you so much, everyone, and have a wonderful evening.